Yeah. So as sir very rightly explained that today's topic is battling the bugs, and I'll be talking on this the part. There are two main important parts that we are going to deal. One is CLABSI and one is VAP. So I'll be talking about CLABSI, that is central line associated bloodstream infections. So before proceeding to central line associated bloodstream infection, let's learn a little bit about. Give me a second about what exactly is central venous catheter. So, as you know, I hope I am audible to all.
Yes,
Am
ma'am.
I audible?
Sure.
Yes,
Okay.
audible. Audible.
Okay. Okay. So basically,
Yes.
what are the central line catheters? They are, we call it as central line also, and these are basically intravascular devices whose distal tip terminates in the large central veins, like superior vena cava, inferior vena cava, or right atrium. And the basic, what for what we use it, it basically give us direct access to central circulation for administration of fluids, medication, nutrition, blood products, or for hemodynamic monitoring. So a little bit about types of catheters. So you will come to know what all the kind of catheters that comes under the what we can call as central line catheters. They are the non-tunneled CVC catheters. Then there are tunneled CVC catheters, dialysis catheters, peripherally inserted central catheters. We call it as PI PIC lines also. Then are umbilical catheters, implanted ports, and these all catheters are usually used to provide short, medium, and long term venous access in all settings. Then a little bit about tunnel catheters. They are basically surgically inserted catheters. And in what happens in this type of catheters, only the end of the catheter is brought through the skin. And the best part is we can use these catheters for months to years. I mean, when you have to use it for a long term therapy, these are the best choice to go for. Then comes the non-tunnel catheters. Non-tunnel catheters are basically, they are the catheters, they are placed percutaneously, and they are basically mainly for temporary purpose. I mean, you can use these type of catheters only for few days to maximum 3 weeks. So then comes the PIC lines or the peripherally inserted central venous catheters. They are more, they are basically inserted through a direct puncture of a superficial peripheral veins, and then they are basically used for, can be used for weeks to months. And the whenever we have to like go for a long term therapy, like long term like IV access is needed, these are the again choice of catheters we can go for. Then comes the another type is umbilical venous catheter. You all know that is these type of catheters are the choice when you need IV access in newborns, and these are the catheters that can we can use only for short term venous access. Now, little bit about sites of insertions. So, when we're talking about central venous catheters, mainly internal jugular, femoral, and subclavian veins are the sites that one can choose for. We'll see in further slides about the sites little bit more. Then, basilic and brachial veins are again choice for the when we have to use PICC lines. Now, a little bit about indications. See, when we use central venous catheters, this again is very, very important. So, whenever we use, there is a hemodynamically unstable patient is there, and you may need to give vasopressor support, you can go for central venous catheters. Or in cases when you have to go for hemodynamic monitoring, like you have to measure the central venous pressure and all, then also you may need to go for CVC. Then there are hyperosmolar agents when you have to give, or when there is inadequate peripheral IV access. In addition to these, as I told you, the hemodialysis or catheters are also known as are also comes under the category of central venous catheter. Then there are patients and we have to give TPNs. That again is an indication for central venous catheter. Even chemotherapy, mass blood transfusion, these are the conditions where we need central venous catheters. Now, directly coming to CLABSI, which is central line associated bloodstream infection, basically we can define is as the recovery of a pathogen from a blood culture in a patient who had a central line at the time of infection or within 48 hours before the development of infection. This timeline is very, very important, or we can count it as more than 2 calendar days as well. So, why it is important to know about CLABSI and why the CLABSI bundle, prevention bundles is important. to know the depth of this situation or this condition, it is important to that we understand the burden of CLABSI also. So there is a study that shows that CLABSI are a major cause of morbidity with mortality rates of approximately 15%, and in some cases 30-day mortality as high as 33.6%. And it has been reported that CLABSI can significantly increase the length of hospital stay also. So it is a very, very important thing that we need to deal with. And if we talk about cost impact, a single case of CLABSI can cost as much as $48,000 or more for per episode. So you can see the burden of CLABSI. So there are some risk factors also which can increase the risk of CLABSI. So we will quickly see few of the risk factors. First, we will go through the patient-related risk factors. So once you know about the risk factor, it will be easy for you to recognize and deal with these risk factors. So as you all know that the premature infants have an immature immune system and their thin is fragile, so that puts them more at high risk of CLABSI. Then there are extremely low weight birth weight. This is again make them more at risk of developing a CLABSI. Prolonged hospitalization, because there is more exposure time, the more hospitalization time will be there will be more exposure, and that again leads to this infection. Then underlying illness severity, like already if a child is having sepsis or there is a prolonged need for TPN, all these conditions again aggravate the situation. Then if the child is already immunodeficient or is already having some adjacent morbidity, that also raises the risk. Now we'll go to another risk factors, few of like line related risk factors. So even the type of catheter also adds on the risk. Like if we use umbilical catheter, say that is if left for more than 7 to 10 days, that again adds the risk. Then if we talk about non-tunnel catheters, as compared to tunnel catheters, non-tunnel catheters are having higher infection rate. Why so? Anybody in the group can answer this? I really appreciate you if you can type in the chat box or you can raise your hands. Anybody? Okay, basically what happens is the tunnel catheters, as I told you, that we surgically insert these catheters and only the tip of the catheter is accessible. But in case of non-tunnel catheters, they are percutaneously inserted catheters. So they are in close access, right? And what happens, there are chances of colonization of bacteria is more uh, and can easily happen. So they are more prone to high risk infection. Then, in case of multiple lumens, when we are using triple lumen catheters or double lumen catheters, they are because there is greater manipulation and therefore the risk of colonization is again more. Even if there is improper trip placement, that again can lead to risk of thrombosis, infiltration, and arrhythmia can also occur. Now, regarding the risk factors, regarding the care and maintenance related risk factors, if I'll talk about, if there is breaks in aseptic technique, like during insertion, excess, or dressing change, that again increases the risk. And if there is frequent line manipulation, as I told you earlier, and another risk factor is poor hub disinfection. We'll be talking in further slides how to deal with risk factors, right? Then if there is a loose, soiled, or dressing related issues, again, that raises the risk. Failure to perform daily review of the line necessity, infrequent tubing changes. All these are care or maintenance related risk factors, and the risk is huge. Then comes the environmental or system related factors like overcrowding in an ICU, if there is limited staff or they are not competent or not trained enough, or there is lack of standardized bundles, right? That again increases the risk, or if there is inadequate surveillance and feedbacks. So we will understand the role of bundles with these graphs or these studies. This data which you can see on your screen is, you can see there is on your left screen, there is a bar graph. This basically is a data from the National Surveillance Network, which indicate that the neonatal ICUs are particularly vulnerable with rates close to 14 per 1,000 line days. So you can see the burden is more as compared in neonatal ICU as compared to the adult and pediatric ICU, right? And the reason we have already discussed in the previous slide because of their prematurity and rest of the causes. So now we will see what is the impact of bundle implementation, right? So there was a study from South India, and you can see the graph which is there on the left side of the screen, which shows that there is a clear reduction in VAP, CLABSI, and COTI across implementation phases. Bundles can lower infection rates significantly, and not only this, they help us to sustain improvement over time also. So this clearly show that the role of care bundle is very much there, and it actually helps us to bring the this infection rate significantly, and also for the sustained maintenance as well. I hope I am audible and things are clear. Am I too fast or too slow, guys?
You are you are audible, and it's
Okay,
okay.
okay. So moving ahead. So, whenever we're talking about central line care, there are a few key principles that one need to keep in mind. One is aseptic technique. So it is strict hand hygiene and sterile precaution at all times. See, at all time is one thing which is very, very important. Minimal handling, access line only and when necessary. And along with that, we can even club the our different procedures as well, like sampling and giving medications that can also be clubbed together so that the minimal handling can be maintained. Then comes the closed system. These are the few four core principles that one need to take care. By saying closed system, maintain a closed infusion system so that to reduce the infection risk. Then daily review is again very, very important. We have to assess ongoing need for the line, and it is very important. Along with the care, you have to assess for the whether it's required or not, or it is important to remove as soon as no longer it is essential. Then comes the hand hygiene. We all know the importance of hand hygiene. So, along with antiseptic soap or alcohol based rub before and after any line contact is essential. And it is actually important, and it is a good practice if you use sterile gloves for dressing changes and any line access. Then comes the line access. For line access, there is a procedure. Uh, there is one thing that you can always ensure. We call it as scrub the hub. So basically, what you have to do, you have to spend 30 seconds to scrub the hub. After your hand hygiene, you have to uh, uh, clean the hub area for 15 seconds, and for the next seconds 15 seconds we have to let it dry. So complete 30 seconds needs to be spent for this scrubbing the hub. Then comes use sterile technique for connecting and disconnecting IV tubings. It is again very important. Minimize line entry that I already explained. And is maintaining aseptic non-touch technique is very important, because see, it is very, very important that you don't touch the sterile areas to maintain this technique. So now there is a dilemma, or there is always a concern about flushing the central lines. So what happens is a routine flushing. There are different guidelines, but the CDC says that routine flushes with normal saline, 0.9% normal saline, are considered safe and effective for neonates. Yes, we can use heparinized saline as well, which is like zero point 0.5 to 1 unit per ml, but it is important that it has some risk also. But there are studies that shows that even normal saline flushes are equally important. And but if we want to go for low dose heparin, that also can be used. So but it doesn't overweigh the benefits. So the best practice can be using normal saline flushes as default and reserve low dose heparin for selected indications. Or I must say that again a better approach is to stick to your hospital policy. That is again very important. So ensure all fluids are labeled and dated, and use infusion pumps for accuracy. Because what happens is we sometimes these heparinized salines can be flushed, so you have to keep very you have to take care of this thing very diligently, that because this heparin can cause bleeding, thrombocytopenia. So all these things need to be taken care, and always, as I told you, unit specific protocols need to be followed. So again, if you are giving even the low dose heparin, you have to look for bleeding, thrombocytopenia, and even the coagulation profile need to be checked. Regarding the dressing and insertion, so umbilical lines and all need to be uh, proper dressing should be there, and a sterile dressing need to be placed. And it is important that you inspect at least once per shift. If I talk about PIC lines or the central lines, see, transparent semi-permeable dressings are advisable and are more preferred ones. But if there is a leak or soakage, you can go for gauze dressing also. And if I talk about when to change, transparent permeable, semi-permeable dressings can be changed every 7 days, or if they are visibly dirty. But in case of gauze or other dressings, like depending upon in which whatever resources you have, you can go for, change it on daily basis or as per your hospital policy. And definitely, if there is a visible soil, you have to change it immediately. And whenever you have to, hello, hello, may I
Yes, you
request
can
all of
continue.
you
Yeah,
to
please carry
kindly
on.
mute.
Please
Yeah, yeah,
carry on.
yeah.
Somebody has unmuted and
Yeah,
speaking
yeah. Please
actually.
unmute yourself so that others won't get disturbed. So while changing the dressing, it is important that you look for redness, swelling, drainage, or leakage. And it is again important that you secure the catheter to avoid the migration of that catheter. So regarding the tube and cap changes, these are very small. See, I really request whosoever is talking, kindly mute so that we can go ahead. So tubing and cap changes, these are very small things, but it is very important that all the IV tubing connectors and caps, I
ये
request
मैम
organizer to do it
मैम
like,
या मैम थोड़ा आप रुक जाओ प्लीज स्टॉप फॉर सम टाइम because
yeah,
they have
yeah,
to
yeah,
stop first the those who have unmuted.
yeah, 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 that's better.
uh, Please request everybody to
Shweta
mute
Thakur, can
yourself.
you mute yourself? Shweta Thakur, can you mute yourself? Shweta Thakur, to mute yourself.
I think
If you have a number,
organizers can do it at your own end also. You can mute all the participants.
if you have a number, please call her
Oh,
and tell her to mute, it's actually quite disturbing.
There is a flow. I think Madam Shweta is busy somewhere.
Yeah, maybe now you can start. Yeah.
Okay. Yeah.
Continue,
I was
please.
talking about tubing and cap changes. As I told you, these are very small things but matters a lot. Like changing IV tubing connectors and caps need to be changed ideally 72 to 96 hours, or if they get contaminated, that need to be changed immediately. If we talk about TPN lines or lipid infusions, that tubing needs to be changed in 24 hours. Monitoring and documentation is again important. We have to assess the insertion site, lymphofusion, and catheter function at least once per shift. And the signs of infection like fever, irritability, elevated CRP, and WBC need to be checked on regular basis. It is important to record the catheter length, insertion site condition, dressing integrity, and fluid running status. When to remove the central line catheters? See, it is whenever it is not medically necessary. That is one indication. If there is evidence of catheter related bloodstream infection, that again are indication when you need to go to remove the central line. If there is a persistent occlusion or malfunction, can anybody tell me if you find any occlusion, can we push the line or we should not? I really want participants to please um, give answers. You can
no, we
type in
can't.
the chat box.
No, we should not do.
Okay, okay, good. So we should not do that. If there is signs of thrombosis, extravasation, or leakage, again we need to remove that line. So complication recognition is again important. There are some red flags that we should never ignore. If there is temperature instability, along with the local inflammation sign, if the patient, the neonate is having unexplained apnea, bradycardia, or there is sudden increase in oxygen needs or feeding intolerance, that again can indicate bloodstream infection, and we need to look into the. We should never ignore those signs. And if there is sudden swelling of limb adjacent to the catheter, then also we have to we can suspect thrombosis. And if there is a continuous bleeding oozing at the side or some large hematoma is there, we need to think about there could be coagulopathy, or there could be a bleeding risk. And if the patient is on even on low dose heparin, we should stop that heparin and we should notify the team. Now I'll talk about central bundle care. See why it is important to have bundle and what exactly is these bundle care. So we have till now talked about quickly about what exactly is central catheters and what all basic care need to be done. So these basically bundle care is it refers to a standardized set of evidence-based practices. They are designed to reduce complications, especially central line associated bloodstream infection, and when inserting and maintaining central venous catheter. See why it is important to have bundle care. See, we all are humans, and we all are this tend to forget things. And what happens when there are set of evidence-based practices as there? They can be in the form of checklist at your bedside, so that ensure that the quality care is provided to the patient and you won't miss anything. So that is the beauty of these bundles. And we will when talking about central line bundles, we can divide these bundles into two parts. One is central line insertion bundle and one is central line maintenance bundle. So first I'll be talking about central line insertion bundle. So the best practices during placements, which comes under central line insertion bundle, is hand hygiene. So hand hygiene is a must before catheter insertion. Then comes the maximum sterile barrier precautions. Cap, mask, sterile gown, sterile gloves, and large sterile drape is a must. Then comes the chlorhexidine skin antiseptics. These are the preferred. If because of anything it is contraindicated, one can go for povidone iodine, but usually that is avoided because that can be written to the skin. So chlorhexidine is the best to go for as it has a broad spectrum. Then is optimal site selection is again important. As I told you in one of the slide that we can go for internal jugular or subclavian or femoral. But see, femoral has the more chances of contamination because of the proximity with the if the child passes urine or there is a that is a area one should avoid. And yes, if I go talk about that we should avoid femoral lines as much as possible because of the risk of contamination, there is higher infection risk is there. Then daily review of line necessity is again important, and it is important that you remove as soon as it is not needed. Now coming to central line maintenance bundle. Again in maintenance, once you have inserted, now you have to maintain the central line. For that, again, the first and foremost important thing is to maintain the hand hygiene before and after handling the line. It is very important. Aseptic technique for all lines, access and dressing changes. And it is important that you maintain this all the time, right? Then catheter site care, as I told you, how to maintain how to do the dressing, and it is important to use sterile, transparent, semi-permeable dressing. I really want participants to answer why this sterile and transparent dressing is important, or what are the benefits of using transparent dressing. Anybody from the group, you can raise your hands or you can type in the chat box.
Regularly check for the local infection, symptoms of local infection.
Yes, if there will be any oozing or bleeding, that will be clearly visible. You can easily access that area. Regarding the dressing change, we have already discussed. In case of transparent, you can go for till 7 days. And for gauze, you can go for one daily on 2 days, depending upon the resource availability of resources or your this setting protocol. Then disinfect catheter hub by injection ports and connectors with alcohol or chlorhexidine. The scrub the always remember scrub the hub technique. Then replace administration set according to the guidelines, usually 96 hours, and daily assessment of site for signs of infection is very, very important. So these are the few points. These are the central line maintenance bundle that one need to always stick to. In the summary, I just want to say that central lines are lifelines in the NICU, but also high risk of infection and complications. Strict aseptic technique and minimal handling are non-negotiable. Daily review of line necessity prevents prolonged unnecessary exposure. Proper maintenance, dressing, tubing, flushing keeps the line safe and functional. Remove promptly when no longer essential. And one take-home message which I really want everyone to take with you all is every touch matters. So protect the line, protect the baby. So who can prevent the spread of infection? I want everyone to answer. Who can prevent the spread of infection? Come on.
It is
All
all of
healthcare.
All
Yeah,
the
it is
health
we. It is we.
personnel.
Yeah. Thank you so much. It's you. Thank you.
Okay, thank you, Ms. Neetu. It was really nice and informative. And most of the principles are actually applicable in neonatal setup also, because mostly what we are interested in umbilical vein lines and UVCs and PIC lines. Okay, those femoral central lines and all are not put in newborns, so they are probably not that relevant, but the principles follow the same, like whatever was discussed. So anyways, so we will take up if any questions are there little later. So now we move to the next speaker, that is Major Junti Jan Das. She is a clinical instructor at College of Nursing, Army Hospital, Darenda, Delhi, and she has been involved actively in all the NNF activities. And now we'll move over to her presentation. Okay. And as like CLABSI, what she will be basically discussing is the second part, that is the ventilator associated pneumonia prevention bundle. Okay, so when we talk of infection in newborn babies, primarily these two are the major routes. Of course, the common factors are the same, the hand hygiene and other things that was discussed just now, but there are some specific things for VAP prevention bundles. So over to the next speaker. Yeah, Major Junti, please.
Thank you so much, sir. So may I know if my presentation is visible?
No, it is not visible.
Oh, not visible. You have to share.
Yes.
Okay, Jubilant, you can share the slides for her. I think she's finding some problem. I have sent you on WhatsApp. There's some technical issue must be on her side.
Sure, sir, just give me some time.
Yeah, basically, I shared the same slides with you. Major Junti must be finding some problem in sharing. So if you can share for her and change the slides.
It will take some time. It is getting downloaded.
But I'm trying.
Okay. Meanwhile, what we can do, if there are any questions, we can take. I think they may take some time. Any questions from anybody for the previous speaker?
Sir, there are two questions in the chat box for Neetu ma'am.
Okay, okay.
Uh,
I'll,
First
I'll,
is,
yeah, yeah. You can also take. Yeah, please tell. Yes.
yeah, there are two questions that I have taken from the chat box. One participant had asked to reinforce why non-tunnel catheter are more at risk of infection. Neetu ma'am, can you shed more light on this?
Yeah, as I told you that the tunnel catheters are surgically inserted catheters, and they are the catheters which are only the tip of the catheter is at the skin insertion site. And so what happens is there is less bacterial colonization, and what happens in non-tunnel catheter, they are percutaneously inserted catheters. So in those catheters, there is more high risk of bacterial colonization, and because of that there are more chances of or higher risk of CLABSI or infection.
The second question is regarding your view on flushing the line in case of PIC lines in extremely low birth weight babies, or for that matter, in neonates.
See,
Neetu ma'am, your
flushing
view.
is again, there was a complete one slide on flushing the lines, in which I
Yeah.
have clearly explained that the choice of fluid for flushing is a 0.9% normal saline. But yes, if and that is quite sufficient. There are various studies that have shown that that is sufficient enough to maintain. What is important is that you have to flush the line frequently, like before and after giving antibiotics, or before and after giving any TPN or any other solution. So that is again important. But yes, in case if that actually if you want to go for heparin, you have to, that is a unit specific protocol, you can go for low dose heparin as well.
Yeah,
But usually
basically,
sometimes
why?
we don't
Yeah.
we
No,
it
no.
is a central lines we go for. So please
Yeah, basically, why this question was asked, because in extremely low birth weight babies, those flushing volumes will also matter a lot.
Yes.
yeah.
Also, the chances of infection and those things. That's why it was asked. So,
So that's
you
the
can
reason
step in.
I
Yeah.
stressed on clubbing the care. See, that has two benefits. One is that will go for, like, that will add the minimal handling. And what will again happen? See, if you club two, three things, that will decrease the amount of flush that you have to give every time. So you can go for that.
Yeah, okay. So actually, few more, like not few more. I mean, she has already described all those. What is very important, particularly in a NICU setup, is that daily check for the requirement of your central line, that is PIC line in our case. We are not really talking about the central lines at femoral and all those places. We are basically As I said, basically there are two lines in NICU. One is your UVCs or USC, but then USC is not for as a not used as central line for giving nutrition or anything. It is primarily the UVCs and the PIC lines, and every day we must see that whether it is required or not, because it's quite a, I mean, in a way dangerous thing to keep it if it is not required. And the what universally it is kind of accepted is that in NICU setup you primarily put a central line, PIC line, oblique UVC is primarily for nutrition. And I mean, like some units use PIC line or UVC because the getting peripheral lines may be difficult for a small baby. I mean, it can be a relative kind of requirement, but it's not that sound, thing to do, in the sense that everything has got its own dangers, so what that's what, like, it's a very calculated call as to whether you need that center line or not. Decide that, and if it is not required, just remove it. I mean, that is the best way to handle in very small babies. This aspect is a bit different from a relatively bigger child. I'm sure Dr. Sanjeev will agree with me. Dr. Sanjeev, you can also have your opinion on this. That's
Yeah, absolutely, sir. For extremely low birth weight babies, where we place PIC line, where it is very difficult to insert as well, I
yeah,
think the flushing of the line volume becomes voluminous for that small baby. So
yeah,
what we normally do is, if the line is not in use, we still keep the line patent by maybe running the line 24 into 7 by small volume like zero point 0.5 to 1 ml per hour, and calculate that volume in the total fluid volume calculation as well. We have to minus the subtract that volume, so that
yes,
the volume overload does not happen, especially in very small
yeah,
extreme preterm babies.
correct.
I fully agree with you on that. There is
Yeah.
another question from a participant. This is again to Neetu ma'am. Can we collect samples for blood culture from the existing lines? I think both
For
Subhas
blood
sir and ma'am can answer.
For actually, it is actually important. You have to, whenever we talk about CLABSI, so taking cultures, you actually need to take two samples, one from the periphery and one from the central line. It's very important. So that's it, I think.
I think Subhas sir will have some difference of
Yeah.
opinion as far as neonates are concerned.
Absolutely. Actually, that is what, like, as I said in the first place itself, that most of the principles are correct, but they're
Yes.
not really true for NICU. So again, for PIC lines, I have never taken a blood sample through PIC line, actually speaking.
I'm talking about the central line. So
Yeah, yeah,
whenever we have
that's,
to go for central
yeah.
line catheters, two samples are mandatory. I
No, no,
mean,
ma'am. That is what
okay.
exactly what I am trying to say. That as such, central line मतलब NICU में दो ही lines होती है,
Okay,
UVC और PIC
understood.
line.
Hmm.
Okay, so हम छोटे small babies में 700 800 grams, you can't put like all those femoral line and all those things. It is not done like that. So it is primarily the PIC line,
Hmm.
basically. Okay, for first few days UVC and then eventually all go for PIC line. So PIC line से हम blood नहीं लेते हैं. Okay,
Hmm.
so that is it. Anything Dr. Sanjeev would like to add?
I absolutely agree with sir. The basic, what ma'am is trying to convey is how to diagnose CLABSI. Yes, of
Yeah,
course, for diagnosing CLABSI, we need to have the same bug isolation from one blood sample taken from the central line and one from the peripheral blood sample. Both should have the same bug. Then only we can diagnose it as actual
diagnose.
CLABSI.
Yeah,
But in
correct.
neonate, it is very difficult to get that much amount of blood. Suppose 1 ml blood from the peripheral, from the central line, and 1 ml again from the peripheral prick source, then it becomes very much too huge iatrogenic blood loss. Number one. Number two, from the pre-existing central line, we don't take any blood sample, particularly from the PIC line. From
Yeah,
the freshly inserted UA or UV, we can take.
can
Suppose
take.
we are inserting for the first time, and we can take samples, but ideally also in that case also it should be avoided. because getting access to through the umbilical veins or arteries are very easier compared to the PICC line, but the chance of contaminations are really high. So how we diagnose is if the central line is already is there in situ for last 48 hours, and we take a sample from the peripheral site and it grows some bug, we tend to take it as CLABSI unless
Yes.
proved otherwise.
Kind of surrogate diagnosis, you can
Yes,
say.
absolutely.
True. So these are some nuances of dealing with small babies. Actually, there are real practical considerations. Even though, in principle, whatever Miss Nitu is telling is all absolutely all right, correct. But there are some specific nuances for an issue. That's the problem. So, okay, the next speaker, is she ready? So any other question we can go on, like, because I have heard Miss Nitu actually earlier also. If ma'am you remember, in a hemato-oncology conference at AIMS. So I was amazed at her like kind of understanding and insight. Yeah, only the only challenge is ki how do we apply those principles in NICU? That's itself a challenge. I mean, being a very
Agreed,
small
sir.
baby
Yeah.
and very limited kind of devices that we have, that is the thing. Otherwise, whatever you're telling is absolutely right.
Yes.
Absolutely right.
Neetu ma'am, I need a little update from you here regarding many participants might be asking themselves what this closed line circuit means and how we manage it in the pediatric or neonatal ICU setup. I think it will be of beneficial if you can throw some light on that.
By saying closed circuit means that it is important that you don't open the line and only open the line as and when required. You properly keep a Lurla caps on that, and even the PMO lines should be very well. It should be tight enough, and all those. That is the only meaning of closed circuit, and open only when as and when required. That's
Subhash sir, how do you manage a closed circuit in your unit to prevent CLABSI?
Yeah, basically, those again small things that you don't fiddle with the line much and don't disconnect and then reconnect. Those kind of things as far as possible, and like continuous flow of fluid, even if it is 0.5 ml per hour or 1 ml per hour. I mean that is good enough, and we also don't flush repeatedly and just continuous flow. It is enough. So basically that only, that you don't disconnect and reconnect, those kind of things. Just let it go. As I was telling, we use PIC lines or central lines only for nutrition. Only for nutrition. And primarily the indication remains that only. And the moment you feel that baby has come to some feeds and the TPN is not required, just take out the line. I mean, it's not required. I mean, that's what we do. Anything, Dr. Sanjeev?
Yes,
To add?
I completely agree with you on that. There is another participant that if culture comes positive, should we take it as a CLABSI? As far as in neonatology is concerned, if the line is in situ for the past 48 hours and the baby shows signs of infections and you are taking blood culture from any peripheral site and it comes as positive, we take it as a surrogate marker of CLABSI. We don't take sample from the central line itself to confirm it. Even one blood culture with line in situ for past 48 hours or after removal and within 48 hours of removal, we take it as a CLABSI. Yes, I think our next speaker is ready with her
Yes.
Is it
slides. So we can go to her to see
Okay.
what she has to say about VAP bundles. Yes.
Yeah, Major Junti, please start.
Thank you so much, and I'm really my sincere apologies.
No problem, no problem. These things do happen. It's absolutely fine. Please start. Yeah.
Good evening, everyone. So today I'll be speaking about ventilator-associated pneumonia prevention in the NICU, which is a very critical component in neonatal patient safety per se. So we all know mechanical ventilation saves lives, but it also increases the risk of device-associated, particularly the VAP. So I'll start my presentation with a quote. Bundles don't save lives. Consistent adherence to bundle does. So we all know that we all talk about bundle care, bundle care, bundle care. But thing is, this quote highlight important conception in the infection prevention. So hospital often introduce protocols or bundles, but the effectiveness depends entirely on consistent implementation. So a single misstep such as hand hygiene or oral care can break the infection prevention chain. So many studies from neonatal intensive care unit have shown that higher compliance with bundle animals significantly reduces the VAP rates. Now coming to the topic, ventilator-associated pneumonia is one of the most common healthcare-associated infection in ventilated patients, whereas in an ICU setting, the problem is even more significant due to the immature immunity, prolonged ventilatory support, and invasive procedures. VAP also increases the hospital stay, antibiotic exposure, and healthcare cost. And risk of mortality in premature neonates is also high. Coming to the definition, ventilator-associated pneumonia, that is VAP, is a type of hospital-acquired pneumonia that develops 48 hours or more after endotracheal intubation and initiation of mechanical ventilation and was not present at the time of intubation. So the infection should not be present or should not have been present before intubation. There are various clinical signs which we can monitor, like the respiratory deterioration, radiological evidence, and some microbiological confirmation when there is a chance of VAP or when there is a VAP. So we'll see respiratory distress syndrome and signs and symptoms of sepsis. So why neonates are at high risk? Because neonates are especially the vulnerable due to the several physiological and clinical factors. They have immature immune system, they have fragile airway structures, they have frequent suctioning of endotracheal tube, invasive procedures like reduced cough reflex, so there is an ineffective clearance of secretion, and particularly in term of preterm, infants with respiratory distress syndrome have prolonged mechanical ventilation. That's why they are at a higher risk. Coming to the pathophysiology, first is the colonization of oropharynx. So within hours of birth, microorganisms begin colonizing the oral cavity. So there is a biofilm formation on the endotracheal tubes or the other tubes. So that's where the bacteria attach to the tube surface and form a protective biofilm. So the secretions containing bacteria leak into the lower respiratory tract, and there where is microaspiration happens. So when the mechanical ventilation reduces natural airway defense mechanism, there is impaired mucociliary clearance. So suctioning of circuit and manipulation may introduce pathogen. So these mechanisms ultimately lead to the infection of the lung tissue. So there are many common organisms which are present in NICU which causes VAP, namely the Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter species, Staphylococcus aureus, coagulus negative staphylococci. Many of these pathogens are multi-drug resistant in hospital organisms. These infections are often associated with prolonged ventilation, antibiotic exposure, and invasive devices. This makes the infection prevention even more critical. So the burden of VAP in NICU is substantial. VAP leads to increased duration of mechanical ventilation, longer NICU stays, higher antibiotic usage, increased healthcare cost, higher neonatal mortality rates. Studies indicated that implementation of prevention bundles can reduce VAP incidence by 30 to 50% in many NICUs. Therefore, prevention strategies have a direct impact on the neonatal outcomes. Now coming to the VAP prevention bundles, evidence have shown from neonatal studies that hand hygiene, head of bed elevation, oral care or suctioning, ventilator circuit management, early weaning, and avoid re-intubation positioning strategies. These are the few bundles which are there in the studies. So we'll see one by one each of them. Coming to the first thing, hand hygiene, which is a single most effective method of preventing hospital infection. It must be performed before touching the patient, before ventilator manipulation, before suctioning, after contact with respiratory secretions, and after patient care. Alcohol-based hand rub or proper hand washing should be strictly followed. Studies have shown that improved hand hygiene compliance directly reduces VAP. Next is positioning. The positioning helps to prevent aspiration of secretions. Maintaining head elevation whenever it's possible up to 30 to 45 degrees if the baby is hemodynamically stable, and avoid unnecessary supine positioning. Ensure that the proper alignment of ventilator tubing should be there. This reduces the gastric reflux and microaspiration, which are major contributors to VAP. The third is oral care protocol. Oral care protocol is an important but often underestimated component of VAP prevention. The oral cavity acts as a reservoir for pathogenic bacteria. Ventilated neonates develop dental plaque, colonization of oropharyngeal secretions. So regular oral care helps to reduce the microbial colonization, prevent aspiration of infected secretions, and maintain mucosal integrity. And we should avoid aggressive cleaning in the preterm babies. So we can do it with the gentle sterile water oral cleaning can be there. So neonatal, we all know that neonatal oral mucosa is extremely delicate. It has very thin mucosal lining and poor keratinization with high vascularity. Therefore, aggressive cleaning or chemical agents can cause us injury to the oral mucosa. So that's why sterile water is preferred, because it avoids chemical irritation and preserves the natural oral microbiome. And it is extremely safe for the extremely low birth weight babies or infants. So the recommended method is to use a sterile gauze or a foam swab and clean the tongue, gums and buccal mucosa very gently and avoid forceful suctioning. So frequency as per NICU protocol, the microbial load in ventilated neonates increases due to the mechanical ventilation, orogastric tube, and reduced salivary flow. So to prevent this microbial colonization, every 4 hours for ventilated neonates, it can be done before and after feeds in high-risk neonates, and more frequently if there is thick secretion is present, oral thrush is present, and excessive drooling is present in the baby. Regular disruption of the bacterial biofilm helps reduce risk of aspiration. And we have to avoid aggressive cleaning, as I have already mentioned, because over aggressive oral care can cause harm to the babies. So risks included like mucosal injury, bleeding, increased infection rate, and discomfort to the neonates. Therefore, oral care should always be gentle, sterile, and atraumatic. So emerging evidence that recent researchers have suggested that probiotics to reduce pathogenic colonization, improve ventilator circuit technology, and biofilm endotracheal tubes enhance infection surveillance system. And maternal breast milk used for oral immune therapy provides IgA and lactoferrin. And it has also shown that oral care combined with colostrum application, it's work as an oral immune therapy. And it helps in reduction in late onset sepsis. Coming to the ventilator circuit care, the routine care change should be avoided. Change only if it is visibly soiled, and the drain should be condensate away from the baby. And follow strict aseptic technique during circuit handling. Frequent circuit manipulation increases the risk of introducing pathogens into the airway. The fifth point is minimal and aseptic suctioning. So you basically the closed suction system is preferred, and before that and it should be done under a very aseptic technique. Excessive suctioning may cause mucosal trauma, increased infection risk, and airway inflammation. And before that, pre-oxygenation to be done whenever it is indicated. So there is a video which I have downloaded. Just see this.
In this video, we will learn the technique of endotracheal suction. Wherever possible, this procedure requires two persons. If a clinician deems it necessary, he or she may undertake the procedure without assistance, and in this situation should alert the other nearby members that the endotracheal suction is being done. The indications of endotracheal suction include desaturations or bradycardia, visible secretion in the endotracheal tube, absent or decreased chest movement, increased carbon dioxide levels, increased work of breathing, irritable or agitated baby, and conducted sounds. The person should perform hand hygiene using alcohol-based hand rubs, followed by donning on sterile gloves. The helper attaches the suction tubing to the suction source and the suction catheter. Open the suction catheter from the hub side only. Set the suction pressure at 100 centimeter of water. This is checked after occluding the suction catheter near the hub. The suction pressure may be lower for a small or unstable infant or slightly higher to remove thick or tenacious secretions. Make sure that only the hub of the catheter should be open and attached to the suction tubing and not the tip. The catheter tip should not be removed from its sleeve, and the key part, that is the part which has to go inside the endotracheal tube, should not be exposed before the actual suction is performed. The depth of insertion aims to reach the tip of the endotracheal tube. Generally, we are able to visualize maximum graduations on the endotracheal tube, which lies outside the mouth. Hence, a prior estimate of depth should be done by adding the length of the undergraduated tube, including the endotracheal adapter, to this maximum graduation mark. Pre-silence alarms and increase the fractional inspired oxygen concentration by a maximum of 10% above the baseline FiO2 requirement. Perform hand hygiene once again and wear clean gloves. When the primary clinician is ready, he or she removes the suction catheter from its sleeve after kinking the catheter near the hub. Ensure that the suction catheter does not touch anything that could contaminate it. A possible source is the bed linen. The assistant disconnects the endotracheal tube from the ventilator at the level of endotracheal tube adapter. The primary clinician introduces the suction catheter to the predetermined length, ensuring that the kinking is still maintained. After that, once the catheter is inside, the kinking is discontinued so as to apply negative pressure. The primary clinician gently rotates the suction catheter as it is withdrawn from the endotracheal tube. Note, the negative pressure should be applied only when the suction catheter is being withdrawn from the endotracheal tube. The duration of negative pressure should not exceed 5 to 6 seconds so as to prevent hypoxemia. Assistant then reconnects the ventilator tubing to the endotracheal tube and continues to provide comfort to the infant and keeps a vigilant watch. Repeat suction may be required if the volume of secretions indicates another attempt, or a clinician determines that another attempt is necessary. Make sure that the saturations are acceptable before a repeat attempt is done. If the endotracheal secretions are thick, the assistant can instill about 0.3 to 0.5 ml of normal saline in the endotracheal tube, ventilate for a few breaths before another attempt at endotracheal tube suction is made. After this, the clinician suctions the oropharynx and the nasopharynx to remove the secretions which can accumulate there by the same tube or an 8 to 10 French tube if required. Observe the infant's post-suction physiological parameters and finally dispose of the contaminated catheter, perform suction tubing flush using sterile water, remove the gloves and perform hand hygiene once again.
So as you have seen in the video, they have used an open suction. So we have talked about, but closed suction is preferable. So next point is daily assessment for weaning. We have to always document and look to the baby whether the baby is ready for extubation. So daily assessment is important and reduce the duration of mechanical ventilation to avoid the risk of infection. Next is antibiotic stewardship. Itself is a topic in it. So antibiotic stewardship is overuse of antibiotics, which contributes to the antimicrobial resistance. It includes using of antibiotics only when necessary, selecting appropriate antibiotics, limiting the duration of therapy, and reviewing culture results. And responsible antibiotic use help prevent emergence of multi-drug resistant organism. So now coming to the key outcome. In recent neonatal research in 2025, it's shown that neonates with VAP bundle had far lower VAP rates than controls, improved respiratory metrics and survival, and supports that bundled care is effective even without universal neonatal VAP guidelines. Successful implementation of VAP bundles results in the reduced NICU stay also and better overall patient safety. The core VAP bundle components are hand hygiene before ventilator care, 45-degree elevation when safe, daily assessment for weaning, ventilator circuit care, careful oral and non-oral secretion management, prevent accidental extubation. When all components are applied consistently, infection rates significantly decreases. Now coming to the monitoring and compliance. Monitoring compliance is very critical. The strategies which includes in monitoring are infection surveillance, audit of bundle adherence, feedback to the healthcare teams, continuous education. Regular monitoring ensures that standards are maintained and team training should be there, and engagement, when there is a team training, then the results are good. And continuous feedback is the most important key to improve the staff sustainability. Coming to the common barriers, when there is a staff shortage and work overload is there, and lack of training, poor compliance, and lack of monitoring system are the common barriers in implementation of VAP. So there are few strategies which can be applied to overcome these barriers. First is to educate regularly. There should be some of the health education or health teaching should be given, and then that staff should be taught about the latest protocols. And there should be leadership protocol. So it's the NICU is a teamwork. The leader, when a leader will leads a team, it's not a thinking that sorry. So leadership support should be there. The team leader of the NICU should take all the co-workers along with them, including the fourth grade staff, the nurses who are working, the doctors, the residents, and including the students who come over there. So it's a role of the leader to teach them and to make tell them about the latest protocols. And there should be audit and feedback cycle should be there. And there is a dedicated infection prevention team should be nominated in the NICU, though those who can maintain the HICC record of the NICU, and culture of safety and accountability should be there. There are a few success stories that which have reported that significant reduction in VAP rates after bundle implementation. Some units have even shown that there is near zero VAP rates through strict compliance, regular audits, and team collaboration. So all these are possible when there is a teamwork. Coming to the nurse's role, the role of a nurse, it's a very critical role and a central role in infection prevention. They are the frontline defenders against device-related infection. The responsibilities includes maintaining hand hygiene, performing oral care, monitoring ventilator care, identifying early signs of infection, ensuring compliance with protocols. And they are the first observer of the respiratory changes because they are there 24 hours in the NICU. So hygiene of hand hygiene and ventilator tubing hygiene, that all should be maintained, and documentation is very much important. The take home message are bundles are powerful tools to prevent CLABSI and VAP. Consistent and compliant single intervention is the only single intervention which can help in prevention of VAP, and you have to educate, monitor, and feedback. It matters, and evidence support bundle as best practices in NICU. So neonatal care is not only about saving lives, but ensuring safe and high quality care. Preventing infections like VAP is a shared responsibility of the entire healthcare team working in the NICU. By following few evidence-based practices, we can protect our most vulnerable patients. So I'll end my presentation with a quote: excellence in NICU care is measured not only by survival, but by safety. Thank you.
Okay, thank you, Major Junti. And again, a very nice presentation, very passionate and uh, real words of wisdom by both the speakers. And as I was telling, I have heard both of them earlier, and I have absolutely no doubt whatever they said is just pure gold. The challenge is the implementation part, and we all agree from within that there's no dearth of knowledge about what needs to be done. It is how much we are doing and how much we are doing at our own. That is the second part. I mean, as somebody was telling, one of the speakers, I am not recollecting, that it is not, it's every time are you hand washing, every time are you seeing that the bundles are being followed. That is what matters. I mean, one odd time somebody, one person is not, that committed, and that's the chain breaks, something like that. In fact, I was just going through the questions. The questions are also, I mean, similar only in the sense that, like, the last question I'll take: how can we monitor on daily basis that adherence to VAP bundle is followed? I mean, everything was discussed here. It is that somebody needs to do it. That's the catch. Okay. So anybody would like to answer that? Maybe Major Junti, the question: how can you monitor on daily basis? It is just as simple as that. Somebody has to monitor it. But then,
Yes.
can you put it in a better way?
Yes, sir. Like, sir, in NICU, we have the intake output chart. So there is a column in which whenever there is a baby is on ventilator, we maintain he's on which ventilator, when the circuit is changed. So in through that, the intake output chart is a very important but the critical document in NICU. You can check out from there, and you can maintain this thing. You can maintain the sterility. You can know the what all is done with the baby, even if you're not in that sheet. But if you maintain the documentation is important. If you're doing documentation properly, then everything can be solved easily, I guess, sir. Anything else?
Yes. I agree. I mean, it is that like if you are not documenting, you are not doing it. As simple as that.
So
So,
sometimes
so,
we think that
so
that
some
we
kind of
forget about it.
checklist, some kind of developing a culture of doing it, that is what will matter. And as I was telling for the previous speaker also, that the best thing is to avoid, intubation as much as you can. You try to extubate as early as you can. These are like actually very easily done, in the sense that, like, somebody, like, there was a time many years back, Dr. Sanjeev will agree with me. I mean, the baby was intubated and then used to be on ventilator for long. Then we came to ensure that, you just take out the tube. What is the need of the tube? And now we are at Lisa. We are not even intubating. Malab, in my NICU at R&R, probably the only babies who get intubated are the surgical babies, truly speaking. CDH, TEF, those cases. Preterm babies we hardly intubate. Matlab, I can vividly remember in a year ki okay, these two or three babies were only intubated. It's as uncommon as on today. I'm sure it's the case everywhere. So something like that. You just, I mean, there will be some inherent risks. One, baby is intubated, and fiddling with the tube, again disconnecting, connecting, and so many issues. So the best thing possible is that if you can, manage the baby non-invasively. But yes, we should know about what needs to be done once the baby is intubated, and that's why these two classes and beautifully taken by both the speakers. So going to the next question, somebody asked again, Dr. Major Junti, for you, and it's like asking those breast milk smearing that you are doing, how many times you do in a day. That's what the question is.
So that
Oral immune hygiene, yeah.
So, as I've already mentioned in my PPT, that it should be done, ideally, it should be as per protocol, it should be 4 hours. But if
Yeah.
there is thick secretions is present, you are seeing there is drooling, then it should be done, and very gently it has to be done. I mean,
No, 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 no. This is asking about oral immune therapy. That you said, no, breast milk to be smeared inside oral cavity. That is what she's asking.
yes, it was in a studies, it has been shown, which we are not practicing, although here, this I have read in the one of the article that they
Uh,
this uh,
okay. No,
uh,
no, you are right. You are right. Actually, basically, breast milk is very powerful. So this breast milk smearing for small babies, it is a routine thing. Why even intubated babies, even otherwise also. Like suppose a baby is NPO, you can always, mother's own milk you can smear inside oral cavity. It is done 4 to 5 times a day. It's absolutely like routine thing. So it has not. I mean, I'm just for the person who has asked this question. This is not typical for a baby who is intubated only. Even a baby who is NPO otherwise, you can smear oral cavity with breast milk. It will do good. Okay. So that's what I wanted to say. Okay, then any other question, Dr. Sanjeev? Anything I'm missing?
Sir, I have a question for you and Major Junti ma'am.
Yeah.
Regarding the oral chlorhexidine care, do you practice in your unit, or do you just go for breast milk and colostrum care only?
I don't use chlorhexidine in my NICU. If Ms. Junti has anything to add, yeah.
till I have worked in 4 5 NICUs all over India, but we are not using it. It's a kind of irritant. Even as an adult, when we use it, it's a irritant. So it's sterile water is the best one, and the colostrum and mother's milk is the best one.
Yeah. Uh,
Anything, Dr. Sanjeev, are you using? Like,
No, no, I was just going through it. That
okay,
some
okay, okay.
units are in the trial phase, so I was just inquisitive to know about whether our counterparts are using in India or not.
So
Okay,
it's
okay.
I am not using it definitely
Yeah,
for.
I
even
can work for four
even
five
even, even I have not used ever. Yeah.
Yeah.
It's not used.
Uh, I think we have no more questions left. I hand over to Jubilant. Jubilant, can you take the proceeding forward?
Yes, sir, sure, sir.
Just
So, first of all,
Jubilant.
I would like, yeah, yeah,
Sorry,
sure,
Jubilant.
sure, sir,
There's
take it.
just one comment by one person, Miss Sujita, that sometimes the checklist can become tick list. What's your opinion? Again, as I was telling, see, there has to be a culture, a culture needs to be developed in the unit. I mean, of course, you are right. This actually happens, but then everybody has to be very honest from within when they do it. I mean, it should not be a tick list. It should be a checklist. I mean, I don't think anything else I can say. But your comment is absolutely valid. Many people actually, just fill up the list, ticket, but it should not be done like that. You see, for every baby, we are answerable, and the accountability should come from within, and it is not only for the doctors or nurses, anybody inside an ICU, even the mother. I mean, every life is precious, so we have to take it like that. In somewhat spiritual answer, probably I'm giving, but then that's how it is. Okay, it's the checklist or culture developing. Well, what is the like? This was told to us by Dr. Vinod Paul sir and others at AIMS, that the difference between, let's say, the Japanese and other people is that they are absolutely honest to the core. If something is written steps at 1, 2, 3, 4, 5, it will be done like that. 1, 2, 3, 4, 5. I mean, there's no reason to deviate from there. It's something like that. Once it is, there's a quote also that first we have to know what is good, and then once you know what is good, then be good at it. So it's like that. So it has to come from within, and all of us have to evolve and see that no harm is done by our hands. That first principle of medical ethics is that do no harm. I don't think there can be a better example of that than from NICU, where nobody is seeing, the baby is not seeing, mothers don't know what we are doing, but still we have to work from within to see that we do no harm, and preventing infection, whether it is CLABSI or it is VAP, it is, I think the principle is do no harm. No, what do you say, Jubilin? You can add something.
Yes, just sir. I wanted to add one thing to what Sujita just said. Like once we fill the checklist, if it is not in our usual routine, so for example, I'll just give you an example. If for morning shift I'm coming, for the next shift some other nurse is coming, and for the third shift some other nurse is coming. So for the sake of just ticking, I'm doing it for one day, or and the other shift nurses are also doing it for one day. So probably for 1 week we'll do, for probably 2 weeks we'll do, and once we do just like that for a month, it will subconsciously register to our subconscious minds, right? So even if we don't want to do it, if at all we are sleeping, like for me it usually clicks like that. Even if we are sleeping, like for the next upcoming shift we have to do this. Why? Because a new regimen or a new duty or a new practice has been incorporated into the unit, right? So we subconsciously gets registered to that practice, I think, like that.
And one more thing, I mean, the other practical answer or practical thing to add is that it also depends on the number of staff. Once you have better staffing, then these checklists are actually followed. But if there is less staff and too many babies, probably these kind of things do happen more. I think that is what is the
Hmm.
practical problem, challenge. Yeah.
Okay, so now I'll take this moment to thank our moderator, Dr. Subhash sir. Sir, thank you so much for wonderfully moderating the sessions and introducing beautifully both of our speakers. And I want to take this time to thank our beautiful speakers, Ms. Neetu Taneja and Major Junti Das, for carrying us into the beautiful sessions of how to prevent this infection or the introduction of infection to the NICU, and what is the optimal use of the bundles. For summarizing, I would just like to say that the life of any living being is like very important. So neonates are like very vulnerable population, right? So it is our utmost importance that we avoid any use of any invasive lines or invasive procedures. If at all it is needed, for example, the introduction of CVZs or central venous lines or any ventilator usage, we need to routinely assess for its I mean expulsion or extubation, right? And the proper maintenance, how it should be taken care, and how asepsis should be followed if the central venous lines or if any ventilator is in use, that should be strictly followed. I mean, there should not be any halt to that procedures. And lastly, I would like to add that there should be continuous routine surveillance and monitor for the same. So how could we do, or how could we carry out this continuous surveillance, is by the routine use of checklists only. Once the checklists are filled and routinely documented, then we can follow up with the surveillance of that particular unit. So I will be handing over to Ms. Bhavna later on. Sir, I just wanted to add one concept of ANTT, just 2 or 3 slides. Can I share if you are
Yeah, sure,
permitted?
sure. Yeah, why
Yeah.
not?
Oh,
In
okay.
fact, I
Okay,
would
okay.
request these speakers, if it is fine with them, the PPT or in a PDF form should be actually shared with everybody. Both the speakers spoke beautifully, and it will be a ready
Yes,
reckoner
yes.
kind of thing. If it is fine with the speakers, I think the please share the PPT and PDF. You know.
So it will be fine if they send it in the PDF file and I'll be sharing that in the
Yes,
group.
exactly. Let them not
Yeah.
send in a PPT format, maybe in a PDF format,
Yeah,
so
in
that
the
it will be
PDF
there.
format, that will be
Yes, yes,
fine.
yes. Yes, and
Sure, sure.
before we finish, I would also request Dr. Sanjeev to speak because he was there throughout with us, and
Yes, yes.
it will be very, very important.
Sir, over to you,
Thank you.
Sanjeev sir.
Thank you so much, sir, for your beautiful insight into both CLABSI and VAP. I also would like to thank Neetu ma'am and Junti Das ma'am for excellent presentation. In fact, I was also thinking in the same line that the PPTs were so nicely made that I was about to request Junti ma'am to share the PPT itself. I was so much uh, fascinated with her presentation, especially the PPTs. So it would be great if they share in the PDF format to us for later, our later as a study material for our other staff also in our unit. I would also like to thank Jubilant for her excellent coordinating this session. And yes, Jubilant, if Bhavna can come and chip in for some of her insights.
Bhavna, you can share your insights, then after that I'll share the screen.
Okay. So, like from both the PPTs, at the end, I would like to, like, few points, I would like to conclude that we all know about the healthcare associated infections, and it is a significant global challenge because according to WHO also, we know that 7 to 15% of hospitalized patients, they acquire HAI, and neonates specifically, because they're more vulnerable. And device associated infection like CLABSI and VAP, we know that they are very much prevalent in, especially for preterm and very low birth weight babies. And so many intervention studies also note that this CLABSI rates, they are nearly 40 to 70%. We can reduce them actually by doing so many NICU quality improvement projects. So we can do RCA, and so many quality improvement projects can be done. And for VAP, researchers specifically, they mention this proper suctioning, oral hygiene, health elevation, and they reduces VAP rates by 40 to 60%, that I have that they you have already studied in the previous slides. And hand washing, hand hygiene, that is, it accounts for the reduction in of HAIs nearly 50%. So, aseptic insertion practices, maintenance of central lines, making skin integrity, and daily evaluation of device necessity, that is mentioned by Subhash sir also, that reduces the infection rates. So, quality improvement in interventions that includes daily checklist is very important, and environmental cleaning, that is the major portion of the intervention for patient safety. So at last, training programs and competency-based education, that I am feeling that this must be done for nurses and healthcare workers that have shown the improved compliance, as well as that reduces the infection rate, specifically CLABSI and incident. So at last, we can say that vigilant nursing care, teamwork, and continuous adherence to these guidelines is essential to create safer NICU environment and improve neonatal survival. Thank you. Now over to Jubilant.
Okay, thank you, Bhavna. Like So I wanted to introduce, I thought speakers would be taking, it's okay, I'll take. There was one topic of ANTT, which I earlier introduced in one of the sessions during the summarization of the sessions. So ANTT is known as aseptic non-touch technique, and it encompasses wide range of practices. So it constitutes the minute details of infection prevention for the optimal safety of patient care and reduction in hospital stay. So touching the non-key elements and excluding the touch of the outer things and the key elements are very important. So we'll see that just as the VAP bundle, ANTT is also a set of bundles or set of principal cares which are combinedly done to ensure that the patient safety and infection rate is reduced. Patient safety is prompted and infection rate of patients is reduced. So what is the aim of ANTT? It reduces the risk of introducing harmful pathogens into bloodstream of patient by maximizing ANTT. So before knowing the concept of ANTT, we need to understand that there are three key important terms for ANTT. That is, this is just for an example of injection administration. So when we are going to administer an injection, so we usually gather up all our articles and we prepare the necessary injection or the drug, and we take all that gathered articles towards the patient side, and then whatever is needed we administer it to the patient, right? So for ANTT, one of the important term is general aseptic field. So in that comes the sterile tray or the trolley in which we are preparing. So autoclaved or sterilized tray comes in the general aseptic field. Then comes the critical aseptic field, that is the sterile gloves which we are using. Then all other things which we are using apart from gloves comes under the micro critical aseptic field, which includes the usage of sterilized hubs or covers, or the ones which are readily available in the plastic wraps or covers, and they need to be specifically handled aseptically. Insides of recently opened equipment package which is sterile, such as gauze or alcohol wipes, syringes, needles, and medicine. There comes pre-prepared packed of medicines that we directly administer to patients, that needs to be also handled very aseptically. So what I need to say is that we can touch using non aseptic technique to the general aseptic field. That is, if both of our hands are utilized as sterile field, but if suppose in any emergency condition or if in any emergency situation there is no assistance for me or no help is from the nurse's side or from the doctor's side when I am doing an aseptic procedure or a sterile procedure. So we can use a non-dominant hand for the general aseptic field, right? So we can, if I'm a right-handed person, my left hand would be utilized for the general aseptic field, that is the autoclaved or sterilized tray. Then for the critical aseptic field and for the microcritical aseptic field, again I have to change the gloves and open the sterile hub covers and sterile equipments that are already pre-prepared in the micro wraps and the covers that directly comes from the manufacturing units, right? So we can do one thing. If I'm utilizing the non dominant hand, I can use it as a non sterile hand. But if some helper is with me or assistance if I am getting, then the person needs to be asked to help me with the opening of the plastic wraps for the sterile equipments. So, for more clarification, I just wanted to say, so in this sterile tray, we can see that there is needle is there, cap is there for the syringes, and one open syringe part is also there, the open part of the hub. So these are the micro aseptic field. So we never have to leave this micro aseptic field just like that, right? We don't have to keep them open. Either we will cover it with the micro ports, or we can cover it with the needles, or we can cover it with the micro caps that we get with the three-way stopcocks or the micro stopcocks that we receive. So we always have to cover them, and we have to reinsert them in a sterile proper aseptic way. So these are the key parts. We can see that IV sets hub and the microport that IV set is IV set is looped into, that is the microport and the hub of the syringes and the needles. These are the very key parts which need to be handled just in a sterile way. No other technique is to be followed or no other technique is to be utilized. So incorporating these key parts for the ANTT by ANTT can reduce many harmful pathogens into the bloodstream of the patient. So this was just the summary. Thank you.
Thank you, Jubilant, for that insight into the aseptic non-touch technique (ANTT). I think many of us will be introduced to this aspect as a new aspect, and of course, we need to work on that, maintain asepsis all the time, and my key message will be to minimal handling as far as possible. In fact, in our unit, what we do for extreme preterm babies is we put a stamp over that: don't touch the baby without hand wash and minimal handling, so that it is visible all the time. Those who have got the tendency to go and touch the baby, they will think twice before touching the baby. So over to you, sir, to summarize the classes and have a last insight into this topic.
Yeah, thank you. I think nothing more to add. Already everything is discussed. I agree with Dr. Sanjeev and all the speakers. It's all boils down to hand washing, hand hygiene, minimal touch, observe more, touch less. Okay, and avoid your central lines or intubations as much as you can. And once you have put it, then also plan as early as possible you can come out of it. Okay, and once they are these line is central line is there or intubated, then follow the principles that were discussed by the both the speakers. You will get, hopefully you will be getting the PDF also, and it will be shared. So just follow those basic principles and improve your unit culture of do no harm concept. Once you bring everything in do no harm kind of thing, no, then after that your most of your problems automatically will go away once you see it from that perspective. Okay, I think it was beautifully done, and the entire program is also so nice to see. And the nursing staff, they are the ones who will bring changes. I mean, we as doctors, we are there, but we know in our heart of heart, if one group can make the maximum difference, it is you, the nursing staff, nursing officers. All the best to all of you. Please keep doing good work and save as many babies as you can, and safely. That is what both the speakers said. I think we can stop here, sir, unless there is anything else.
Thank you so much, sir, and thank you to the faculty and sir for sparing your valuable time to be with us for this session. I hope the participants, we will have more participants in the next session as well. So it's good night from us. We will be meeting you on the next Wednesday as per schedule only. Thank you and good night.
Thank
Good
you, sir.
night. Thank you.
Thank you, sir. Good evening, sir.